Assalamu alaikum. My name is Vardashar, having roll number BB1650250, a member of Group 33. The topic assigned to my group is adverse effects of drugs on liver. And the subtopic that I'm going to discuss is pathophysiology of hepatic injury. What do we understand by pathophysiology of liver? So, liver is a strong, flexible organ which can easily resist toxicity due to its unique cellular structure. Despite of this, there is a possibility of being attacked or harmed when exposed to different agents in their most reactive, or we can call it as toxic forms. As we all know that liver is located between GI lining and drug targets within the body. The oral drugs first enters the circulation, then undergoes first pass metabolism, which leads to the exposure of drugs or toxic metabolites to the hepatocytes, or we can call them liver cells. Also, we have IV administered drugs which may cause damage to the hepatocytes because it receives about approximately 25% of the cardiac output. Idiosyncrasy is a term used to define a condition in which we got undesirable effects of any drug seen only in very less population. Such effects are known as idiosyncratic effects or idiosyncratic drug reactions, or we can call them type B reactions. A minimal amount of drug will cause immune response, but it is suspected that at a low enough concentration, a drug will be less likely to initiate an immune response. They are said to be concentration independent, as individual susceptibility is determined by patient specific factors. This may relate to only few number of drugs which varies from patient to patient. They are unpredictable or life-threatening. In other words, we can call them as significant cause of morbidity and mortality for patients. The major targets are skin, liver, and bone marrow. The case we're going to discuss is related to our topic, that is idiosyncratic hepatotoxicity. 1 month after initial visit, CW returns to the clinic with 1 week history of jaundice, anorexia, fever, and nausea, while continuing to take her valproic acid, well-controlled seizures with no change in pattern. Upon obtaining an additional medication history, CW states that she briefly reinitiated her trimethoprim sulfamethoxazole for a couple of days during the last 4 weeks of recurrence for her urinary tract infection and increased her venlafaxine dose to 100 mg TID. Furthermore, we have given laboratory values, which shows ALT 164 units per liter, AST 177 units per liter, alkaline phosphate 105 units per liter, and total bilirubin 2.3 mg per dl. What we have to determine is that what type of liver injury could CW have? And what is the clinical significance of her elevated liver function tests? So first we are going to describe our subject. What is the chief complaint? We've discussed idiosyncrasy, in which we get the undesirable or unpredictable effects of to any drug in any individual. The medical history of the patient shows that she was facing jaundice, anorexia, fever, nausea, and urinary tract infection. And her current medication is valproic acid, trimethoprim, sulfamethoxazole, and the third drug of which the concentration is increased to 100 mg is venlafaxine. The object, which shows the laboratory results. We've got the results of ALT, AST, alkaline phosphate, and total bilirubin. All these levels mentioned are more than that of the normal. In other words, we can say that we've got elevated liver function tests. By all these points, we can assess that the elevated liver function reports indicates that the patient is suffering idiosyncratic hepatotoxicity. That means hepatotoxicity due to certain drugs. These drugs are valproic acid, trimethoprim sulfamethoxazole, and the third venlafaxine. So there may be different approaches to overcome this problem. We've got a plan that CW, our patient, should be advised to discontinue trimethoprim sulfamethoxazole and venlafaxine, as these are the major cause of the idiosyncratic hepatotoxicity. In order to overcome this, we need to discontinue them. And if we don't discontinue, then there may be some toxic metabolites which may cause more adverse effects. Like we can have pruritus, liver inflammation, or many more. So, in order to overcome these problems, we need to discontinue these two drugs. Last but not the least, we have the third drug, that is valproic acid. This drug could cause inherent or acquired hepatotoxicity. So, but there is a condition that in infants and children, those younger than 2 years, are at much higher risk for valproic acid induced liver disease than that of the adults. So we can give this to adults. Like we have CW, so we don't need to discontinue this drug as there is a exception. That was all about my topic. Thank you so much.